Welcome to this Research Capacity Building webinar on research ethics and adult social care. So this is a series of events and activities that we're doing with NIHR Academy to help build research capacity in adult social care. Included in those activities are individual career development awards, and we had a launch of those last year, and we'll be doing a second call later this year, probably around October. So colleagues might want to look out for those. Those are awards to help people apply for funding to support their career development in adult social care, and they should be really good opportunities for people. So please do look out later in the year for those. But we've been running a series of events. Earlier in the year, they were face-to-face, but obviously we've been forced with social distancing to move from that to online. And this is our first capacity building webinar to be done online. And so I'm really grateful to our presenters today, Mikey Dunn and Martin, for taking us through the first one. So this is on adult social care. Mikey Dunn from the University of Oxford is going to talk to us about theories, issues and practical strategies related to research ethics. He'll talk till about 11:45, then we'll have opportunity for questions, and then we'll go on to, I'll introduce Martin Stevens for his session. Just to note, we are recording this session just so that we can use it for future events, put it online as a resource. And also, I suggest that because it's quite awkward being interactive and asking questions in this context, unless people have absolutely urgent questions, that we save questions for the actual allotted time of 11:45 for questions, if that's okay. So without further ado, I'll hand over to Mikey Dunn. Thank you, Mikey.
So thanks for the introduction. It's great to be able to join you this morning. I'm going to sort of set the scene, I guess, a little bit for Martin's more practical procedural discussion at 12. I work in health and social care ethics at the University of Oxford and have an interest in research ethics in social care particularly, and used to be a member of the Social Care Research Ethics Committee as well. So my focus is on theories, issues and practical strategies, but it's going to be sort of building the foundations for what I hope will be a useful, helpful, practical way of thinking about research ethics in your research work. It comes on the back of, and I'm talking essentially to the summary points of a new methods review that the SSCR published just yesterday, I think, on their website, just come out. This is going to give a sort of much briefer version of that fuller review document. So I hope that you may be interested in looking at that for a more extensive summary of what I want to cover. Two main objectives. I guess I want to sort of start really by locating and trying to carve out a space for thinking about research ethics in a very practical way in social care research activities, thinking about the core features of research ethics in social care, how we might orientate ourselves theoretically and in a principled way to thinking about how ethics fits and how it features in research project development, and then how we can apply some of that material to the practical matters of thinking through particular issues in research projects, setting up essentially for questions about defending that, perhaps in a research ethics committee context. But really it's less about the research ethics committee that I'm interested in, and more about provoking the sort of sense that when we do research ethics in social care research, it's helpful to think about it as there from the start, embedded within all developmental work in research activity. So really my points are going to be just as much about thinking about the development and articulation of a basic research proposal or protocol in a way that's ethically defensible, so that it takes into account what might be most ethically relevant and significant to attend to in the basic design of a project. But of course, further down the stream, there is going to be a requirement to defend that, to articulate that, to review that within some form of institutional framework of ethics review, getting an approval from an ethics committee. So in a sense, that's the final stage, I think, for me in defending, articulating and positioning the ethics in that kind of way. So a brief overview about my main sections of the presentation. I'll speak for about 40 minutes or so, as Mike said. I want to start by locating ethics essentially in research in social care by just describing or discussing what I take to be the core ethical tension that lies at the heart of social care research activities that's empirical in nature, and therefore why ethics is a sort of central component and feature of all research of this type. I'll then, once laying out that tension, talk about how we might navigate the tension, and I want to review in rather abstract terms some rather overarching theoretical perspectives on how we might navigate wades through that set of issues. I'll then talk about how that can give shape and be crystallized by reference to 3 specific ethical considerations that I hope will be able to provide a sort of guidance, a set of waymarkers for thinking about the ethical design of research. And then I'll try to consider how that might be put into practice by looking at a couple of examples where we might think there's an ethical tension or try to marshal those considerations to address that tension, before concluding with some points about preparing for the ethics review process that Martin will speak in more detail about. So I think one way of positioning the ethical tension in social care research is to start actually not with research, but with social care practice itself, and to draw a comparison between the two. So I want to say a little bit about social care practice before articulating the difference, if you like, in how the ethical tension arises in research. And I work in the ethics of social care practice as well, so this is sort of the other part of my interest, really. I think it's reasonable to say that the ethical challenges that arise in social care practice largely centre, not completely, but largely centre on navigating competing accounts of deciding what is owed in very practical terms to individual service users receiving social care support. So we might attend to, for example, the idea that when we're thinking about what's good for, or what we ought to do for a service user in social care, one consideration we might address is the idea of respecting that person's agency, to enable them to make their own decisions, to be free to pursue life plans or courses of action that are in accordance with their own values, recognising that they will need support given their needs to do just that. We might also see a requirement to maximise their well-being, to enable them to live a life to a certain quality. And of course, you know, in the ethics of social care practice, there may be an enduring tension between those two kinds of considerations, or indeed other considerations around dignity or fairness, for example. So it may well be the case that sometimes quality of life, in some senses of the word at least, isn't maximised by enabling people to pursue whatever life they want to lead, or there'll be implications for other people's quality of life if we go about doing what we can to respect their agency. But in ethics of social care practice, we are fundamentally concerned with determining what is owed to the individuals that we care for, who fall within the domain of the service that's being provided, essentially. And that's, I think, the nub of the ethics of social care practice, in one way of expressing it at least. But if we turn to the ethics of social care research, we have a different kind of set of trade-offs and different set of considerations at the heart of the activity, it seems to me. In the social care research context, we have on the one hand questions about what we owe to individual research participants who are taking part in the research, who are generating the data by our activities, but also, importantly, what is owed to the future people, some of whom might not even exist yet, who will potentially at some point in the future benefit from the scientific activity in the research projects that we are doing. And those are two different kinds of sets of considerations. And unlike practice, we have this amorphous idea of future people who will benefit from the activity that isn't quite so present in the practice context. And one way of thinking about that different kind of set of considerations or obligations is by imagining wearing different kinds of hats, I think, in the social care context. We could put on the practitioner's hat and say, look, my requirement when I think about research is to minimize risks and to respect the choices of people who are otherwise service users in social care research studies. We have clear practice-connected obligations to those kinds of people. But if we change to the researcher's hat, we're suddenly thinking about something very different. We are thinking as the advocates for doing good science, producing new and important transformative data that could potentially transform in the future through the benefits that the research accrues, the quality of social care services that are delivered. And those two hats don't sit comfortably on the same head at the same time. And that's, I think, one way of thinking about this core ethical tension in social care research, and in some senses motivates everything else I'm going to talk about today. So one question that we face is, how on earth do we navigate or try to address this potential tension between this idea of having two hats in the ring when we think about designing and developing research in a practice context? We do need to come to some decisions. We have to make decisions about whether it's appropriate to wear one hat in a particular kind of way. We have to decide whether the research should, all things considered, go ahead or not on that basis. And one way of doing so is to think about, I think, broad theoretical foundations that could provide some overall guidance to us. So I'm going to go through three theoretical positions that could help us to navigate this core tension that I've described. The first position, a sort of libertarian type view, says we fundamentally navigate this tension by focusing on the rights of the individuals receiving social care services and who might be recruited into social care research studies. And if we take this sort of rights-based view, we're essentially emphasizing fundamentally and primarily the value of the control that participants should exercise over what they do with regards to their relationship with research, to treat them as people who have rights to make choices about whether they take part or not. And unsurprisingly, therefore, this position generally places the focus predominantly on making sure that we have a valid consent from that person, that they fully understand what's going on, that they agree to expose themselves to whatever the researcher is proposing to do. On this kind of position, if we have that consent, if we have that autonomous authorization from the person, the research can go ahead regardless of what it's intending to do. The person accepts the terms of it, the researcher has the permission. And any other consideration that we might otherwise think as relevant, like the harm or the benefit the research might accrue, or the harm to the people who are giving consent, is just not taken to be relevant on this position. If we have the right permission, the research is justified to proceed. And of course, we need sufficient people to agree, otherwise it won't be possible. But if we have those sufficient people, we can get ahead, we can go ahead, and we can do our research without any further scrutiny or consideration. Okay, so that's set against a second position, we might call the duties-based position. And this says we should start thinking about what we owe to people in research by looking at what duties are owed to them, what fundamental obligations that we have. And the move here is to connect the duties in social care research with the duties that already exist in the social care practice context. There are a set of obligations, ethical obligations, that social care providers have to those who receive services, and research should adhere predominantly or almost entirely to those kinds of considerations. And we'll be asking then whether the research is justified to proceed on the basis of whether it adheres to those kinds of duties, irrespective of the potential consequences, benefits or otherwise, that the research might give rise to. Now, we can have a debate about what duties will apply here, but I think one clear duty that we will have in our minds when we think about this position is the kinds of degrees of harm that we should expose research participants in social care to. We might argue that that exposure of harm should not be in addition to the kinds of harm they're exposed to as recipients of services in a social care setting where the research is designed to take place. So we'll be looking at capping or putting a threshold on the degree of harm that the research is allowed to expose participants to. And importantly, on this account, valid consent cannot override the fulfillment of that duty. People cannot be allowed to give consent to things that they would otherwise expose them to harms when there's a duty not to expose them to that harm in that context. So we're going to constrain the kinds of choices that people can make on the basis of harm thresholds, for example, on this kind of an account. And the final position to navigate us through some of this debate is what I'm calling the consequences-based position. And the idea here, unlike the focus on the rights of the participants or the duties that are owed to the participants in the social care setting, we look instead at the overall consequences that come about through the research taking place. And our obligation on this account is to maximize the overall amount of good we can do when a research proposal is being considered. So this is going to fundamentally emphasize the value and quality of the research as a core consideration. Only if our research proposal is likely to be the kind of thing that's well designed and able to accrue benefits to people overall in social care, would it be possible to justify the research on this kind of an account. It also, of course, importantly requires a careful balancing of the overall harms and benefits to people in the future who may not even be receiving services yet, against the harms and benefits to those who are actually giving up their time or being involved in the research activity. Our obligation is solely to maximize those benefits and minimize the harm. So there will be trade-offs to be made between those. But at least in principle, if we take this position seriously, we allow the possibility of a research project that is potentially transformative in its future benefit to social care service users to go ahead, even if it requires people to be coerced, to be denied the choice, and to be exposed to quite considerable undignified or harmful procedures, or burdensome procedures in a research project. The ends justify the means, essentially, on this kind of account, at least in principle. So those are three basic positions. If we were in person, I'd ask you which of those immediately grabs you as being the kind of one you might put your cards behind. But my experience doing this previously is that people are quite reasonably differentiated between them. They have preferences for one or the other, at least in the abstract. People do tend to gravitate towards one or the other. But really importantly, I think, for ethics in research of social care, there's reasonable disagreement about how and which one of these considerations ought to dominate. There is no overarching moral truth of the matter we can point to. And so we're going to negotiate and discuss and argue between them. And because there is no settled decision on that, we don't know which of these ought to win the day. There's no sort of moral certainty around that. It's fair to say, I think, that we can reasonably disagree about which of those basic arguments ought to drive a judgment about whether it's legitimate for the research to go ahead. And so what we've seen happening in research ethics generally, but also in social care, is that those abstract theoretical positions get codified into some overarching ethical considerations or principles that we need to marshal in the design of a research project. And I'll talk about those considerations now, but they give content to specific features that I would argue that those who are putting in place or designing a research project in social care need to attend to, because they are crucial to deciding whether it's appropriate or not to go ahead with the research. And there will be a call to account on the basis of those considerations in the review process. So the first consideration that I mention and talk about in the report, and I define in this way, is an overarching requirement to respect the persons involved in research activities. And this is about the intrinsic value of the people who take part. The idea here particularly is that these people have a certain moral status. We owe certain things to them because of that status. We need to treat them and respect them in certain kinds of ways when we seek to involve them in research. And at its core, this is about the unique individual value and dignity of those people, something that the codes of research ethics talk about as a core principle quite often. On dominant accounts of respect for persons, there are kind of sub-principles or sub-considerations we might attend to. We'll be thinking about the ways in which in our projects we respect the autonomy of our participants, the ability to make sure that if they're going to take part in the research, they're doing so in alignment with their value commitments, their preferences, the idea of the kind of life they want to lead. Also importantly, that their freedom is respected, that the research doesn't prevent them from pursuing the kinds of things that they value. It is not inappropriately restrictive or burdensome in that kind of way. They're not subject to certain constraints that prevent them from doing the kinds of things that they want to do. And finally also, but I think particularly importantly, sometimes it gets missed in medical research ethics, but I think it's important in social care contexts, is a requirement also to think about the dignity and privacy of people who will be participating in research. So this idea of a sort of appropriate relational respectfulness in a research encounter, and how a person comes into a social care living environment and engages with the person, treats their private space in a certain kind of way, doesn't see them necessarily as merely a subject of research, as sometimes it's called, but as a participant with a certain set of requirements to be treated in a certain kind of way, I think is equally important. Now, in the research context, in the social care context, there are specific things that follow from this kind of consideration, obviously, and this is not going to be new to anybody, I don't think. It obviously places central importance on obtaining valid informed consent. And the consent process essentially is the activation of the respect for person requirement predominantly. It's where most of the action happens, but importantly, not the only place, I think. So what we're trying to achieve there is that the person, in line with what they understand appropriately about the project, it's the kind of thing they want to commit to being involved in. It's aligned with their understandings of what's going on and what matters to them. And that's why fully informed, free choice, etc. is all very much part of that. Now, there are implications here for people who lack capacity, but I'm going to leave that one to Martin to talk through, partly because of specific legal considerations that kick in when we're thinking about people who can't give consent on this consideration. We also have to make sure that this kind of offer, the proposal that we're trying to get approval for, doesn't disproportionately impose restrictions on freedoms. I think we want to make sure that freedom is enabled to the extent that it can be. We also want to make sure, I think, that people's confidential information and private lives are respected. If the research involves sharing narrative histories of social care experiences or such like, we need to make sure we handle that information sensitively. And of course, if we're entering into people's private spaces, there's going to be a sense in which we think carefully about how we respect people when we do that, if we think it's justifiable to do so. If we don't, we might exclude entering, for example, into a bedroom or a bathroom to conduct observational research or to do interviews or something like that. Good. So second consideration, second principle that I lay out in the report is a broad obligation to maximize benefits and minimize harms. And you can see this connects quite closely to the consequences-based theoretical position. And the idea here is that in research, we have to strike a positive balance between the benefits and harms that will accrue from that activity taking place. And our focus is on maximizing the overall welfare we can do. So we are considering both the benefits and harms for those involved in the study, but importantly also the potential benefits of the research going ahead for the future people who are not taking part in the research themselves. And we need to be able to articulate that this is a project that has appropriately maximized harms and appropriately minimized risks. Now, in the research context, I think attending to this requires asking a series of questions of the following kind. Firstly, what benefits are likely to occur from undertaking this research? Are there direct benefits to the research participants from taking part? Will they, for example, be given the intervention that might be being tested in the social care context? Will the direct outcomes of an interview-based study have service changes that will impact directly on their social care setting, for example? Can we make that claim? Usually the answer, I think, will be no, not directly, but there may be future potential benefits, and there may also be indirect benefits. For example, there might be benefits from the research being part of a trajectory of research activities of which this is one single part. So we need to see the research program in the round, or as a series of additional kinds of activities. So no direct impact here, but if we do this stage, we can do that stage and then that stage, and then the benefits will accrue, and we can tell that reasonable causal story. Now, these benefits are going to be considered in terms of the methodological quality of the research. The general view is if your research has been peer-reviewed and has been approved for funding, you are on pretty solid ground, I think. But it explains, I think, why ethics committees do take some time to think about the science as well as the ethics, because here the science is directly relevant to the ethical justification for the research going ahead. If it's a very poorly designed study, you might reasonably object this research will not maximize benefits for future participants, and therefore any burden imposed on the participants themselves is not justified. I mentioned already some of the direct benefits to the participants. We might also think, I think, here about indirect benefits, and we certainly talk in social science research, particularly qualitative research here, I think, about the value of being given the opportunity to reflect on a service user experience or considering a particular kind of experience one has had living with dementia, for example. Now, we've got to be a bit careful, that's a positive rather than negative account, but it's quite commonly that people see that giving the opportunity for a person to be able to participate will empower them in a certain kind of way and may have indirect benefits, even if the research outcomes don't directly benefit them themselves. I think we also have to take seriously the idea that there may be harms or burdens that arise for participants. Now, lots of people in the social science world in the UK have argued quite convincingly, I think, that these are less significant than the kinds of harms we impose on people in medical research. As Robert Dingwall famously said, we're not injecting people with green goo and seeing what happens. But there are going to be invasions of privacy. There are going to be ways in which people's time is allocated. They're going to be taking time out of their daily routines. They might find the sharing of information distressing. There may be problems that arise that need action to be taken. So we do have to think carefully, but not and significantly, about the kinds of harms and burdens that could be imposed by research, and not take, I think, just the principal view that social care research is not harmful like medical research. And that's sometimes something that I think we have to fight against a little bit. The final consideration here is what I'm calling fair conduct in research. Once we've attended to treating people respectfully and maximising harms, maximising benefits, minimising harms, we have to think then about what it would mean to undertake the research fairly. And this is really about justice requirements within the overarching design of the research activity. And I think in the social care context, this points to a certain set of things. Firstly, I think what you might be wanting to think about is are we attending to whose social care needs are being foregrounded in making priority decisions about the research activity and its objectives and its focus? So, are we arbitrarily excluding, without perhaps unfairly, subgroups of service users from our sample frame just because it's too difficult, too hard, or too problematic to engage with them? This might include people, for example, who don't have English as a first language. Might include those who live in far-reaching areas of the country, or those in more from lower socioeconomic backgrounds, because it's just easier to recruit people that we have contacts with, etc. That would be, I think, on this basis, potentially unfair in how the research was set up. There may be also questions about whether certain subgroups are being neglected, or I think in something in the social care context, where some subgroups are over-researched. So we sometimes hear stories about how groups with particular genetic conditions, for example, might be subject to endless amounts of research, or specialist services might be subject to particular kinds of research. We might be a little bit worried that there's an unfair burden being placed on certain kinds of people who are particularly interesting to research. And so we need to be attentive, I think, to the fair distribution of the way in which we prioritise the focus and objectives of activities. And we also think I need to think about the way we distribute the risks, benefits, and potential burdens that accrue through research in how we've designed it. So, are there indeed clear pathways to benefit the people who are bearing most of the harms or burdens, those participating? Are there special reasons for thinking these people need to be given more in terms of benefits than those who are, we might call, free riding? They are getting the benefits in the future, but they haven't actually given up anything in terms of participation in research. So thinking about pathways to benefit quite explicitly, I think, for participants would be a fairness requirement, I think, here. We might also think about ways in which people are being unfairly taken advantage of or exploited. We find it easier to recruit certain kinds of people just because we have certain kinds of relationships with them, or because we expect them to participate. People in care homes being perhaps subject to an authority that makes it easier for them to agree to research than they might do if they was in their own home, for example. It's sometimes something people talk about. They're living in an institutional environment where they adhere to requests perhaps a bit differently than if they were living in their own homes. So we need to make sure that the sort of fair distribution of the ways in which benefits, harms, and burdens are distributed, I think, as well. Okay, so moving on. I think with these three considerations, we can navigate quite sophisticatedly how we design and put together and refine a research protocol. Now, it's important to recognise that these are not functioning as an algorithm. We don't sort of work from 1 to 2 to 3 and out pops a decision. Yes, it's ethical to go ahead, or no, it's not. We are reasoning between them. We are modifying, refining our proposals in light of them. We are considering different interpretations of them. All of that, I think, needs to be quite carefully thought through. Nor can it simply be a tick box exercise where we just say, well, I've done respect for persons, I've done maximising harms and benefits. This is designed to provoke sort of ongoing reflection, really, about the quality and the ethical sophistication of the specific tasks of research at every point in its journey. The two questions I would put out there for reflection are, how should these ethical considerations be applied? And do they lead to modifications needed to be made to the design of the research? And most importantly for the ethics, I think here, how do we address conflict between them as they arise through our proposed design? How do we think through potential conflicts and how do we address that? We will have to make trade-offs and we'll have to defend those trade-offs, mainly because there's no a priori theoretical answer to how we balance those considerations. So I'm going to give two examples of how this might manifest itself as a set of considerations in a real world issue in a piece of research. So one common ethical question or ethically relevant feature of a research design is the question of payment for participants. And I mean payment here beyond reasonable reimbursement of travel expenses. So let's imagine that a social care researcher is proposing to pay service users with dementia £10 to participate in a 1-hour interview about their experiences of using a fall detector. We might be asking, from the perspective of our considerations, firstly, does payment infringe or disrespect the person? In particular, might it invalidate consent? We might be thinking, is it coercive? Should we be fully informing people about that payment they'll receive or not? If we inform them, are we using information to coerce? That'll be relevant questions to ask here, I think. Sometimes we ask, would a non-cash payment like a voucher be a more appropriate substitute? In my view, difficult to justify, I think, given the considerations at stake. Looks like it will be equally coercive potentially. It might be potentially less beneficial than a cash payment might be as well, given the kind of investment the person's making as a participant. We might also be asking, will payment benefit participants or cause them harm? We think sometimes that there are unintended negative consequences of payments. It can impact on people's social security arrangements, for example. We might just argue quite strongly, this is an additional direct benefit. If you take part in our research, you get paid for it. And that's the benefit that we want to balance in the trade-offs we have to make. Thirdly, we might argue or consider whether the payment's crucial to obtaining the overall benefits of the research. A researcher might persuasively argue, for example, that if we don't pay these people £10, we simply won't be able to build up a big enough sample, recruit enough people to get the kind of data we need, and so the research will be meaningless. So the payment comes in there to justify the overall value, meeting the overall benefits of the research. We might also ask whether it's fair. It seems entirely reasonable, entirely fair that if a person's giving time out of their day to participate in a 1-hour interview, that we fairly accommodate that and we give a fair respect to that. And we have to make sure that we're doing so in a way that doesn't unnecessarily and arbitrarily exclude some people who would be unfairly treated because they're not being given the possibility of that recompense. Maybe those who are not able to do the interview in English, for example. So that's the kind of way you might think about that kind of question, I think, and an ethically principled way of navigating through it. It's important to recognise that, if you were challenged by an ethics committee, the challenge could go one of two ways. You might propose to pay them, and the committee might say, but isn't that coercive? Are you not worried about that? You might propose not to pay them, and the committee might say, but why not? Isn't that unfair? Aren't you potentially undermining the potential sample, recruiting enough people to the research? So, the negotiations will depend on the arguments presented, and you might be challenged on the basis of the different considerations in that kind of way. I think it's useful having that conversation in your own head as you develop the proposals and prepare, for an ethics committee review process potentially. Okay, sorry. The second quick case to cover, covert ethnographic research in a care home. The idea here, social care researcher interested in examining concerns raised in a recent report by the regulator that contact between care staff and residents in care homes is not supportive of a person-centred approach to realising good care outcomes, being too rigidly focused on the completion of a minimal set of personal care tasks. So the researcher wants to examine how care assistant-resident interactions take place in the home and the explanatory factors that might underpin those interactions. She intends to get a job as a care assistant in the care home and conduct covert participatory research during her shifts. She does not intend, so it says she does intend, but she does not intend to inform the care provider, the manager, the care staff, or the residents that she's doing this observational research, because she's concerned that will bias how they interact and therefore the data that she collects. So it seems that if we look at this in terms of our considerations, we have an obvious striking tension between two of them. A requirement to respect the people who are here surreptitiously being recruited into research, set against the possibility, if we respect people, to produce useless, non-beneficial data. I think to navigate that tension, one will be asking first, well, is the benefits appropriate? Is this a pressing social care issue that we need to attend to and that we need to collect quality data about? I think the argument would probably be yes, if you can make that case on the basis of the literature available. Does the proposed research design enable the beneficial insights to be obtained? Is research of this kind in one care home really going to provide that kind of data? I think you might ask yourself that question and refine the proposal accordingly. Certainly would expect, I think, an ethics committee to ask about that. Would it really be impossible to obtain those insights if consent, explicit and informed, was obtained? Would there really be a problem of bias? Well, I think quite reasonably, yes. I think in a case like this, you could make that case, certainly, but that's the kind of question to be asking. Are there other ways in which we might respect the people, even if we don't respect them by getting consent, we could ask as well. So are we approaching them and mounting the interactions in a dignified manner when covertly researching in that context? And are we trying to correct for the disrespect we've done by not getting the original consent by providing them with a full rationale and information after the event about what went on and why it was justified or viewed as justified to go ahead without permissions? Or, again, the research might argue the opposite, that actually they ought to remain in ignorance forever because the harm of subsequently informing would have such negative ripple effects in the care home environment that it would be unethical to do so. So that could go in a number of different ways, I think, depending on how the arguments were marshalled and how the considerations were explained. That would be the task of the researcher, I think, to take a position on. I'm running out of time, so I want to just finish with connecting to Martin's forthcoming presentation and thinking about taking this sort of very context-specific view on ethical considerations in social care research to the level of the governance of research and the ethics committee process. And this is important, I think, because people will often understand this bit of it, what I said so far, but really struggle with the ethics committee process bit of it and can't see how these things relate. I hope to have made the case that we have to make trade-offs between these considerations in designing research, and we will reasonably disagree between ourselves, and we frequently do in research projects, about how that trade-off has been struck. That's the nature of the ethical judgment. There's a requirement to make trade-offs upon which we can reasonably disagree, I think. People have been criticizing ethics committees as being best placed to make that, to be the authority that judges that trade-off, essentially, that gives the authorization. And I think there's a set of reasonable reasons why we might be concerned with how those committees function, but I don't think there's an argument against the need for that committee in the first instance. You might argue instead that maybe if we equip researchers to consider these things in these kinds of ways, they become the people best placed to make these judgments. I think there's two reasons against that. One is the idea of the sort of social accountability of all research, but it's certainly social care research. And this is the broad idea that society at large has a stake in overseeing research activities, because all research inquiries have implications for how we go about our lives together, whether we need social care services or not, I think. And so we're all appropriately invested as members of society in the activities of what might be quite private, institutionalized research activities. And secondly, the point about contestability. Now, when we face reasonable disagreement about ethical judgments in many other contexts, we generally see that the committee approach to ethical decision making, to giving final authority to yes or no, you can or cannot proceed, is a mechanism for handling that requirement to make a judgment in a fair procedural way when we have reasonable disagreement of that kind. And having different stakeholders who can all see the disagreements or the considerations from different standpoints, I think also prevents the idea of the bias that one person judging it, including the ethicists, one person judging it by themselves might struggle to see beyond. Researchers, of course, are appropriately invested in their research. They wanted to go ahead and succeed, quite rightly, because it's going to be transformative and beneficial. But it can, we might think, I think there is a risk of this, mean that they miss out or don't see some of the considerations in a certain kind of way that a service user might see them, or that a carer might see them. And so the committee allows that multiple positionality to be reflected and carries an authority in the face of reasonable disagreement between the people involved. It can, of course, make ethics committee meetings quite lively, because there will be reasonable disagreement between the committee members often as well. Okay, so finally, I hope that this will assist in people's way to navigate through ethical considerations in designing and refining research projects from the very start of the idea through to its actualization in the real world. I also hope that it will be useful for framing entry into the Research Ethics Committee process, because uncertainty, fear and frustration are common feelings I think we have around ethics review. If it's functioning well, the ethics review process should enable researchers to articulate and defend the kinds of things I've been speaking about today, draw attention to how they've attended to the considerations in their research, and to talk about trade-offs they've made, and to be prepared to defend them against challenge. There are, I think, some concerns about the ways in which ethics features in very institutionalized, proceduralized review processes, and that we actually lose the ability to kind of engage sophisticatedly in that reasoning process. And that's something we should all fight against. But I do think that an ethics review process that's well set up should be supportive of researchers to do just that, even if it does carry the ultimate authority to decide whether you can go ahead or not. Look forward to discussion. Thanks very much. Please feel free to drop me an email if you want to pick up anything else in the future as well. Thanks.
Great, thank you, Mikey. That was excellent, really clear and helpful overview of ethical issues. Please, if you have questions, then perhaps use the chat function that you can highlight towards the bottom of the screen, type in there, and we'll pick up the questions that way. Or if you're not sure about that, try waving or something. But there's so many of you on, it's not easy to see that way. So preferences for the chat, if you type in the question there, please. Mikey, I think in particular, one of the things that was really helpful there is your helpful explanation of why ethics committees consider research methods. I know that's often been a very controversial area with some researchers, where they go to the ethics committee and have questions asked about their methods, that the researchers don't think that that's a legitimate part of the ethics process. But I think you've made it really clear why it is.
Yeah, I mean, I want to be a little bit careful. So, I mean, I think there are some important objections to the way ethics committees might look at the methods. So, yeah, nobody is likely to be better placed to review the quality and the methods of the research than the researchers themselves. And I do think there's arguments that, an ethics committee can look to peer review and approvals from a community of scientific experts as a marker that's covered, that point is covered. But yes, because it's so closely tied to the ability to accrue the benefits, that's why the methods are ethically significant in that sense, definitely. Thank you.
I suppose, of course, the ethics committees don't get to see the review process, so that doesn't necessarily build an element of trust. I think trust is an obvious part of the whole process of approving research from commissioning it and the funder's perspective through to ethics. And I wonder if maybe some of the review process was more transparent, that might help with ethics committees having trust in the methods.
Yeah, I mean, researchers often include the reviewers' reports in their applications, and it's a good idea. And if you can look, if we see that the researchers, how the researchers responded to the review, that's a really useful kind of, again, this thing about just showing this is going to have some benefit. I mean, I think and I think we try and set quite, in terms of the ethical questions, quite a low bar. We need to say that this, if it's so obviously not going to do anything, well, then, because we have to bound it, and it's in terms of what we look at in the ethics committee, and then that in itself causes debates within the meeting.
Yeah, I think you're right, Mike, about that. I think the idea of seeing the ethics committee process as one part of provoking a sort of ethical thoughtfulness on the behalf of the researchers, really the end point of that, because of course one hopes that shaped all of the decisions in designing the project up to that point. But to see it in that constructive way, whilst it has the authority to say yes or no, to see it in that constructive way of provoking ethical responsiveness and thoughtfulness, I think is one way of perhaps of trying to get that message across.
I think one of my slight worries with the process that we have at the moment around ethics committees is that it's often talked about or portrayed as a barrier. It's an issue to get over, to get past, to get on with the research, rather than, as you just described it, as stimulating part of that process of reflection and planning a research project that actually carries on beyond the ethics committee, and all of those ethics considerations are there in the intellectual endeavour of operationalising the project. And I think that's one of my worries about some of the ways that we think or talk commonly about ethics committees, is that it undermines that thinking about the long-term process.
Yeah, good. Thanks, Mike. I totally agree with you on that. You hear that a lot from all sorts of research communities. The idea of getting over the ethical, passing that hurdle, and I think it's a way of seeing it as a stumbling block, not necessarily as a constructive part of preparing a good piece of research. And of course, the ethical considerations will continue even when you've got approval, because you're making day-to-day ethical decisions in research as you think about the evolution of collecting data and such like, and analysing data. So it's always there. It's just a sort of strategy for sort of orientation problem, I think, perhaps sometimes we see. I noted a question here from Francesca, so I'll read it out, shall I, Mike, and then respond.
Okay, that's good. Thanks, Mikey.
I'm quite interested in how ethics committees construct or understand their ethical positions. Is there an ethical framework followed by ethics committees, or do you find that the ethical priorities are uniquely constructed in each particular response to submissions? Do you ever find that there are contradictory positions from the same committee? Good. So, I'm not a member of an ethics committee anymore. I was on the social care rec for 10 years, but I've done my duty and now moved on. But I can certainly comment a little bit broadly about how, from my experience of how committees generally work, rather than specifically in the social care context. There are international research ethics guidelines people will be familiar with. Declaration of Helsinki is one of them, classic ones for medical research. The ESRC has a framework for research ethics as well. In my experience, ethics committees operate slightly differently to the application of those frameworks. They have their own processes that codify the kinds of considerations I've talked about, which are all present in those guideline documents, through a form usually. So you'll be asked questions that, if you dig deeply into them enough, will connect back to the kinds of things I've been talking about today: respecting people, getting consent, talking about harms and benefits, minimizing risks, managing confidentiality, managing privacy. All those things are kind of codified in a process, and that process is designed to promote procedural consistency, as I understand it. So it's really important that all researchers and all committees look at how, in a consistent way, the persons engage with those considerations. and they do so uniformly across them. Now, of course, there may be quite quickly one or two particular issues where there are ethical trade-offs being made or difficulties arising that the committee wants to push back on. Also doesn't have the time to get into everything, but it should be able to do so by recourse to that framework it's operating within, usually an application form, and that will capture those considerations. So it will pick and choose between them, but it should do so consistently. It's quite possible that the committee might come to the opposing decision than another committee would do in considering the same proposal. But so long as it's procedurally considering them and can point to their disagreement being reasonable, that they've reasonably traded off things differently, that, in my view, is legitimate. But if they were randomly bringing in completely different considerations or drawing on a whole different process or couldn't articulate their reasons for rejecting a proposal, that will be problematic. You can certainly find contradictory positions from the same committee, I think. It depends a little bit on, all proposals are so specific that even very similar proposals might fall one side or the other of the line potentially. And it might depend on the views expressed by people on that day. And it's really important the committee can point to a procedure, because that's what authorises the judgment, that is fair and legitimate. And it's not the whim of an individual committee member, for example, that is shaping that decision. But most committees have some fairness and procedural safeguards in place to try to promote that kind of procedural consistency, even if it leads to different outcomes. But there are big debates in the academic research ethics world on those kinds of questions, as you might expect.
Thanks, Francesco. Hopefully that was helpful. Cheers, Mikey. Your example of the payments made me wonder to what extent we have an evidence base behind some of these ethical questions that we face, and whether having a stronger evidence base would actually be helpful to us in some respects.
I think that's absolutely right. Yeah, we need to know about the harms, burdens, and benefits that accrue from certain research methods or interventions being used. So, people will otherwise sort of arbitrarily come up with the idea, well, surely that's going to make the person not be able to choose, or, clearly they'll get more of a benefit from £15 than £10, or from that kind of payment or that kind of voucher. And that will just be largely, non-evidence based. It will be sort of anecdotal experience. I think you're absolutely right. I think we do need to be confident when we're assessing those kinds of things, that we can say, yes, there will be an effect of that kind if we do that, and there won't be that kind of effect if we don't. And I worry, like you, a little bit, that can sometimes just be sort of anecdotal, reasonable interpretation of things. Great. So yeah, research into research procedures that has ethical significance looks like an important priority for research in social care.
Well, I know research into research is a stronger theme in health research generally, I think. Yeah. I don't think it has been a very strong theme in social care research, partly because we don't have the capacity quite so much in social care. But it's interesting to hear from your perspective as an ethicist and a former member of an ethics committee that actually that would be a helpful line of inquiry.
I think so, yeah, absolutely.
Great. Well, thank you very much, Mikey. I think it's time we moved on to Martin. So Martin works at King's College London and is currently the chair of the HRA Social Care Research Ethics Committee, and has been doing that for some years now. Perhaps you can remind me, Martin, in a moment. Martin is going to talk us through to help us understand the ethics committee process, and particularly one of the very structured aspects of ethics in this area, the application of the Mental Capacity Act. Thank you, Martin.
Great. Okay, thanks, Mike, and thanks, Mikey, for a very useful, really useful way of kind of framing, and I think that's a good way of thinking about, just because it helps you identify why you're kind of responding. And sometimes you go back from a kind of emotional reaction to some of the research and back to thinking about, well, why is that? Where does that fit in that kind of thinking? Yeah, no, I've been, as Mike said, I've been chair of the Social Care Research Ethics Committee since 2014, so 6 years now. So you have a kind of 10-year remit at most. And I've also been working at the Health and Social Care Workforce Research Unit I used to be the social care workforce research unit until quite recently, for a long time. So I've kind of seen both sides. I've been researcher going to different ethics committees and obviously been on the ethics committee. So I think that's quite a useful way of, you know, different perspectives. And I think it was an interesting point that was made about this idea about going through the ethics approval process as being a way of developing your thinking. And I know as a researcher, I always found it actually a very useful way of really pinning down what you were doing and then thinking about how that was going to impact on the people who you were hoping to participate in your research. So even though you kind of were dragged kicking and screaming into doing that, in an extent, it was always a useful process. And certainly, although I do take this with a bit of a pinch of salt, a lot of researchers tell us, even after they've got approval and you know they finished, that it was a useful process. So I kind of cling on to that in the face of sometimes the, you know, and the obvious frustration felt, you know, understandable frustration felt by some researchers. So I'm going to focus, I'm going to talk a little bit about just what the approval processes are and a little bit about kind of about their nature and how the different ones fit together, and not 100% clear. And then focus a little bit on the Mental Capacity Act and its implications for research. And then talk about some of the issues we look at. I mean, I kind of base some of it on you know, thinking about the ORS form as a framework, and it does kind of pick out those issues, and you make those arguments in terms of thinking about the ethics that in the ways that Mikey was talking about. And very interesting, this idea of conflicting and balancing conflicting principles. So all the things that, but these, I mean, the interesting thing about the Mental Capacity Act research is that it is probably the only legally kind of binding element of the process. So there are some quite fixed, and then, you know, and that kind of often plays quite, there's quite a tension between that legal framework and a kind of ethical thinking. So it is quite an interesting area. Okay, so just broadly, there are two main elements to thinking about approval processes more widely. There's research ethics approval and kind of governance approval. And the two things kind of, you know, sometimes are a bit in tension. So you have an initial decision, and I'll talk a little bit more about that in a sec, about which kind of research ethics approval process you need to go for. I mean, it is the case that I would say all research involving about social care, whether it involves staff or even just records, because it's all very personal kind of data, need some kind of research ethics approval in the sense of kind of that institutional regulatory kind of thinking. So there is a need for that. Martin, and then as well, whenever you're involving local authorities, and to an extent, although again this is slightly hard to kind of pick your way through when you're involving independent sector providers of social care, you need some kind of local approval, local research governance approval, which is I mean, you know, local authorities, social service, essentially adult social care departments or whatever, Martin, they're now adopted. Pardon?
I'm sorry to interrupt, Martin. We can still only see your first slide in the normal view rather than the slideshow. That's it. Thank you.
So which one could you see? That one? Oh, never mind. There we go. So can everyone see this one now? Is this all right, Mike? Put your thumb up to say yes. Good, thank you. So right, yes, no, that's very strange. It's not quite linking together. Okay, so yes, and I was just going to say, in local authorities, research governance, which is kind of instigated from 2001 too. So it's been around for a long time, but there's never been a kind of linked together properly, you know, consistent approach across local authorities, partly because they were never funded to do it. The level of requirement on them to run research governance processes was variable, and then the austerity of the last 10 years and probably the next 10 years, it meant that resources was, it was an easy thing to cut. But it's kind of looking at what, making sure that research undertaken locally has been, has been checked for methods and ethics, but also, that the organisations are bona fide and to manage what research is going on. And similarly, in NHS, if you involve NHS organisations in your research, you'll need to go through Health Research Authority approval, which kind of covers some of the similar kind of issues as research governance and checks. But then also there's a go to the local trusts and research and development organisations. So there's again quite a pathway in terms of actually getting approval to run research, particularly if you're going to a lot of different places. The Association of Directors of Adult Social Services still run an approval process which kind of covers research ethics and methods and kind of a sense of how much burden it will place on local authorities if you go to more than 3 local authority sites. And that is, that's a can be another step, although I think they've now stopped charging for doing it. It used to be a bit of a sting in the tail when they charged you for getting approval. So they've got that kind of complex system of actually getting research done. And in terms of Health Research Authority, review of social care research ethics, the Health Research Authority became the body. It runs all of the research ethics committees involved in NHS research, and became officially responsible for social care research into that 2015. It was actually included in the Care Act. The Social Care Research Ethics Committee has been around for about 10 years, since 2009, but there's now 2 other very clearly flagged social care recs within the Health Research Authority. So your research might go to any one of those, but I think mostly they're funneled through the Social Care Research Ethics Committee. Now, there is some ambiguity about when you're required to go to HRA rec. I mean, broadly, the information on their website is difficult to interpret, but most social care studies involving people who use services or carers as participants will need HRA rec approval. The only absolutely clear thing is that all social care research that involves people who lack capacity under the Mental Capacity Act has to go through an HRA rec. It doesn't have to be the social care rec, but there are a number that are kind of flagged, of which the social care rec is one, to review Mental Capacity Act research. And they are the approved bodies, clearly set out in the Act. Now, there's a whole range of other studies where you can go to an HRA rec. Some local council kind of run studies where there are big ethical issues, and certainly we see a lot of studies looking at integrated services, and increasingly studies taking place in NHS settings with patients or staff, and we focus on social science methods rather than some of the biomedical kind of methods, although we're broadening our remit over the past few years. Whilst we don't focus on children's social care solely, where children only are participants, studies do come to us where there are both adults and children are research participants. So, and there is some research, I think, that there's kind of an advantage in getting HRA rec approval just for supporting your access, and that's another aspect that, if you have that kind of approval, that will play well with local authorities or providers. It may be seen as a kind of badge. So there is some sort of advantage from going down that route, even though there is some slight ambiguity. And I think work is going on to kind of resolve, to make the criteria clearer. Just quickly going over the process, you have to decide whether your research requires rec review, and as I said, that is a bit difficult. There is decision tool, and I've gone through that several times with various projects, or just thinking about it abstractly, and it does tend to come out that if you are involving service users and carers as participants, you need HRO REC approval. But so that's useful, a useful way of just checking what you're thinking. Then there's the whole process of registering on with the IRAS integrated research application system. Now, as you're developing, before you can submit, and before ethics committees need to see all the research materials that you're going to use, because they are the manifestation of those ethical debates and dilemmas that you go through in thinking about your research, because particularly those public-facing, if you like, documents, or indeed the research, even the research into the topic guides, for example, or observation plans. They're the kind of those, or the kind of manifestation of those ethical decisions. So the ethics committee needs kind of sight of those, which is, so it's about the timing of when you submit your application. But also, if part of the process, part of the methods are that you're taking a kind of iterative approach and you're going to be doing some work in order to support the development of those tools, then you can certainly, we will submit the application, and get a kind of broad ethics approval eventually for undertaking the research, and then submit the developed documents at a later point, again, to get that ethics scrutiny as an amendment. So you have to complete the IRS form, which is all online, upload all the documents you've got, including a protocol, and there's for the research, which is very clearly sets out how you're going to undertake the research, which has more details in the IRS form, but there's a need to make sure the two things match together. And you've seen quite a few studies where they don't, and it causes, delays and questions about what's actually being planned. It's very important to attend the REC meeting that's involved, particularly the students. If the students attend with supervisors, that makes a huge difference. Just to see the kind of support network and organisational backing for student research, which presents particular problems. Now, I think it's quite useful to remember there are these kind of outcomes. I mean, we can get a favourable opinion, and then we don't call it approval, although it is commonly termed as ethics approval. We give a favourable opinion eventually, and that's very rare on the first run through. Very rare to just give favourable. Often there's favourable with minor conditions and these have to be quite minor in the sense of conditions that can be kind of very word-driven or technical, that don't require a further ethical judgment. A majority get what's called a provisional opinion, which then requires further work to the committee's not satisfied with certain elements, and I think there's a big effort made to be very specific about what the concerns are and what we would like to see the researcher do. We try and give as much guidance as we can. And the same when we have if we give unfavourable opinions. What that means is that you then, if you have a provisional, you resubmit for a subcommittee to focus on those specific issues. If you do get an unfavourable opinion, it's not that often that means the researchers go away and just resubmit an altered project. It's just that the committee feels it's so kind of, there's been times when we start trying to rewrite the proposal in the committee and we realise, no, this needs to be going back. But again, we try and give as much information as we can as to why it was unfavourable and how it could be altered. And there are actually very few studies don't get approved in the end. You do get some unfavourable, but they are very much in the minority. And then after you get an approved, a favourable opinion, you might need to submit amendments, particularly around changing or develop new research materials, and finally submit progress and final reports. And there's very limited, there isn't really any monitoring. I mean, it is kind of you get approval and then you can submit amendments, but there are, so, you know, that's a certain point, a very clear point where that then, you know, you're allowed to start developing the research. Although a lot of activities can go alongside developing. You know, you can be working with gaining access to sites and, you know, in an informal kind of way. So it doesn't have to delay every aspect of doing the research. So just thinking about the Mental Capacity Act, passed in 2005, applies to any research. I mean, it has a large number, obviously, elements that relate to practice, health and social care practice, and financial management and so on. The issues about research, it applies to any research in England and Wales where people are unable to give consent. And I'll talk a little bit about what that means in a sec. It covers what's known as intrusive research, which basically means all research involving human participants or their data where you would normally need to get consent from people able to give consent. So that it's a strange, I think it's a strange phrase. It sounds more, it's, you know, it really is almost any research involving people. It sets out, as I said, the requirements for approval in terms of using effectively HRA research ethics committees. It talks about how you have to consult carers or professionals. And the key thing, I mean, is that this is not consent. And I think that, you know, in terms of the way you set out documents, it's important that consultees give advice about whether the participant would want to take part in the research, and they're not giving proxy consent. And that's the key point to remember, I think. And has sets out some additional safeguards, mainly in respect of ensuring that nothing is done that the person who lacks capacity, and it goes back to issues that Mikey mentioned about restricting people or causing distress. There's higher bar in terms of making sure that there is no distress because of people's who lack capacity is perhaps inability to communicate, and you need to have particular attention to that, and then withdrawing people completely if there is that kind of sense that people are getting distressed about research. 5 principles, again, presuming capacity, which is quite, again, it helps kind of thinking about how you manage research. So you do presume capacity. It doesn't mean that everyone with dementia or everyone with learning disabilities, for example, lack capacity. That it has to be and it's about specific decisions. So in this case, this decision to take part in research. And those decisions can be supported, and if you know, providing good information in very simple form, with simple language and in different formats, and providing support to make decisions, then some people who may be able to make that decision where that might have been in question. So it's important that's an important element. And again, something we look at as you know, in the way that research is planned in the ethics committee. People have the right, anyone has the right to make unwise decisions, and that, although this is really a practice issue in the main, it causes a lot of dilemmas around what are the role of social workers and services for people for whom capacity may be under question. All decisions for people who do lack capacity have to be taken in their best interests. But interestingly, that doesn't apply to research. I think because there's kind of a principle that taking part in research it's not in someone's best interest, in the sense that it's very rarely going to have a direct advantage for that person. So you have to kind of give an opinion about what the wishes of the person would be. And you have to do the least restrictive option, and again that goes to those additional safeguards. So any research methods have to have the least intrusion and the least kind of requirement of engagement with the research. So capacity, I thought it's useful just to think about that. It's able to understand, retain and use information to make a decision and communicate that. And that's very key for consent. It's time and decision specific, and that goes to that issue of, you know, it's not around diagnosis or groups of people. And it can fluctuate. It's not necessarily permanent. Fluctuating capacity has to be kind of addressed, the potential for that within research design and how you're going to then think about different ways of getting consent, you know, people losing capacity or regaining capacity. And it's important to remember that anyone with capacity can consent to take part in research. We've seen studies where, you know, particularly with groups of people for whom a large number may lack capacity, researchers develop a process in which all participants, perhaps they'll contact carers of all of their participants to check on whether this is appropriate, and not kind of adapting, you know, making different approaches for people who you know, do have capacity to make that decision, and it has to be their decision, even though they may need support, and that there's a kind of need to really make sure those different processes are applying. And as I said, we're talking about how there are, you know, special provisions for that research. And so you have to, this is how you might assess capacity, and it's important for ethics committee that we see that there's a good process for how that's going to be undertaken, and that the people doing those assessments have the right skills and experience, including within the research team, but also how are you going to rely on carers, care workers to make these assessments. So, you know, it has to be linked to that disturbance, and it's interesting language. That's the language that's used in the Act. So there needs to be some kind of, that's about capacity in this kind of context. And can then the person understand the information relevant to the research, taking part in the research, retain and use that information to make a decision and then communicate it. It does create a real problem, and this is a general, I think, issue around information. What information is it realistic for people to potential participants to take in and understand and use? We've seen, you know, and this is very clear for people who lack capacity, or, you know, and for people who, because you still need to provide that information. So giving information that covers the ground whilst being a reasonable amount of information is a really kind of difficult task, and, you know, needs a lot of thought. I think there is, and I think Mikey kind of, is an important thing to remember, that there is a kind of ethical case for undertaking research and to maximise those benefits. Again, going back to the kind of way of thinking about the very different ethical considerations. But it is important, you know, to improve, you know, services for people who do lack capacity are often complex and difficult, and how we improve those services, it's very important that, you know, that is based on some kind of evidence. So there's an ethical case for including people who lack capacity, just in terms of evidence. There is also an argument about inclusivity and equity of, and that again goes back to the things that Mikey was saying about allowing those benefits from taking part in research. And interestingly, that is an argument that it doesn't kind of play well within the Act, the way the Act is set up, and what ethics committees need to see, although it's a very strong ethical argument. And we have to see a very particular kind of justification for including people who lack capacity. I think because of this sense that there is a much more of a chance of again, not respecting autonomy and possibly causing harm. And it's kind of because people don't have the ability to really communicate and advocate for themselves. And the justification needs to be based on the sense that the research can't be done as effectively without including people who lack capacity. So it has to be based on, you know, what benefits will accrue from the research, and that unless you include people who lack capacity, those benefits will not be realised. And that is the key argument. And we do see a lot of arguments saying, well, it would be inequitous, but, you know, it would be an inequity not to include people who lack capacity in this research. And that is a genuine ethical argument, but it doesn't kind of meet the Mental Capacity Act. And we have, as you know, when I do some questioning researchers in the committee, we kind of sometimes have to kind of tease out that that is an effect on the research, and we need to hear that, and this is a very, you know, it's a legalistic kind of requirement. I thought this was quite a good one. This is about a study of focusing on people who with learning disabilities and experiences in acute hospital settings. And the key thing there is that people who lack capacity particularly are most vulnerable to it's focusing on compassionate care. And they, first of all, those people were most vulnerable to not experiencing compassionate care. And then to understand how to develop compassionate care for this group, we needed to include different ways of understanding their experiences. And that was a very clear case that research simply couldn't answer the questions without including those people. And it's that case that needs to be made. And then we struggle with this. We often go around, there's several iterations, either sometimes during the meeting, sometimes, you know, after a provisional opinion in a subcommittee, we then have to, you know, go around again. So it's that to keep in mind as the kind of legal basis. And, you know, I think there's an ethical case for that as well, unless you can justify that in that way. You know, that is an ethical case, notwithstanding the kind of equity arguments. As I mentioned, decisions to take part in research, and again, this is part of the Mental Capacity Act kind of legal requirement, they're often confused with those best interest decision making. And we've seen quite a lot of research set up saying the decision to take part will be undertaken within those principles. And we need to see that is true, but we need to see this involvement of relatives and carers as advisors in that process, and not the best. It's not around best interests. In terms of research, you've got to remember the interest of the individual outweigh those of society. So if there's a felt there is any harm, particularly around people like capacity, then, you know, there's a different kind of balance being drawn. And it's important to remember that even though you might get an assessment of capacity from a doctor or a social worker or a social care worker or a carer, researcher has the final responsibility to decide whether the person should take part or not. And that's both in terms of the initial consent, but also on the day. You know, you come to the care home or you go to someone's house or you meet someone and you realise that although they might have had capacity to give consent or it had been felt, but on that day they don't really understand what you're doing, why you're there. So you then have the responsibility to decide and think about how respectfully you can do that, and not to continue with that particular activity. So it is the researcher's responsibility in the end. And you need to revisit those decisions, both in the sense of capacity and fluctuating capacity, but also looking very carefully about any signs of distress or not wanting to take part in a particular activity. And then they need to be withdrawn, and it's very clear that then you don't return and include them again, try to reclude the person again. I mean, it has to be teased out that this is distress around research participation rather than something else. So it's not always a straightforward issue, but we do need to see that that's there, you know, that kind of commitment. And it needs that sensitivity, and this goes to a view of being clear about what the researcher's experience with working and researching with a particular group of people. So to understand those verbal and non-verbal cues about willingness to participate is something, again, that we need to, as a committee, needs to see that very clearly set out. Sometimes it's setting out what might appear to be very obvious. So you've got some questions to ask about your approach to assessing capacity, and we need to see a very clear sort of set out of how that's going to happen, who is going to, you know, if you're going to be relying on opinions of carers or clinical staff, and when and how within the kind of recruitment and consent process, and also the, you know, the interviews or observations, are those assessments going to be made. as I was saying, about skills and experience, and what you're going to do if someone regains capacity. We've seen quite a few studies, and we've had some COVID research studies recently where someone may have lacked capacity to start with, but then regains capacity. So how are you going to then think about, you know, they then need to give consent to further involvement and their original involvement. And if someone loses capacity during the research, particularly if you have a series of research interactions, it may well be that, and legally consent doesn't kind of continue. So even though you consent while you do have capacity, then if you want to, you know, continue to observe that person, for example, after they've lost capacity, it then becomes a mental capacity out research. And you know, thinking about that at the beginning so that you kind of set that up early in your planning is important. You do need to, as I was saying, talking about consultees, and these are who actually give advice. They do not give proxy consent. I've probably repeated that point, but I think it's we see that quite a lot, and it's very useful if you can really set it up with the right kind of language. Basically, giving an opinion. You try and make sure that they try and ignore their own feelings, but that may not be possible about research. They need an information sheet that sets out their role, why they're being approached, but also then gives the information that participant information sheet. Very much written about, this is about the person, you know, the relative, the carer, your friend. Normally, you know, preferred a personal consultee, a family member, and that's the kind of first port of call. If that can't be found, someone can't be found, or then you can approach a nominated, which can be a paid care worker or professional, but someone who's not involved in the study, so someone possibly outside of the particular service that you're working in, if that's a key question. And then that's you know, very much upon a practical issue of who is around and what the questions of the research ask. You have to respect advanced decisions that may be made, and but the consultant, and you have to check that out with the consultee. There are provisions for emergency research. This is usually for emergency health research if there's no time to consult someone, and that's very rare, I think, for social care research. You do have to provide information to participants who lack capacity, and producing easy read, you know, the same, you know, it's really good information. So, and in an easy read, perhaps, is one particular format, but making sure that using appropriate language and formats, time to provide that information, and think about support from family members in explaining the research so that people can take as much role in that decision to take part in the research as possible. And as I said, the information for consultees, explaining why you're contacting them, and giving them good information about the research. And it's important to find a way of making sure that consultees can keep in touch with you, and you can keep in touch with them in case they change their mind, in case something happens, in case you need to consult them again about particular parts of the research. It's important that you adapt methods for involvement. We have seen studies that, you know, want to include people with lack capacity, in fact need to include people with lack capacity, but then want to do hour-and-a-half long face-to-face, you know, interviews with people, or expect people to be completing questionnaires. So, you know, adapting methods is really important. So there's meaningful and genuine response to, because, you know, again, to justify that intrusion. So using simplified questions, minimizing the intrusion, which is kind of another kind of principle of mental capacity out research. Thinking about types of interviews and more informal methods, and we've seen all sorts of ways of working with photo elicitation and things like that. So I'm really thinking through what is a good way for people to take part in the research. I'm running out of time, but I'm nearly finished. Lots of observational studies, and they are complex. Often, you know, to think about how you manage the people who are not the actual participants, but maybe under the researcher's gaze, and what information is needed. and so on. But they're you know, obviously a very important method for working with people who lack capacity and thinking about different communication aids and approaches. Proxy methods, we debated that long and hard in the committee. I think the key thing is that it must be acknowledged that this, although you know, this is not the person who lacks capacity, it's not their views, it's not their experiences, this is someone else's opinion. And that just, I think it's just about framing those questions and making that clear to whoever is going to be the proxy. And while thinking through some of the confidentiality issues about how that's managed, about someone else giving a lot of information about another person, and where, and this is the part of the issue I think came out of Mikey's presentation too, that there are often no hard and fast rules about this. There are factors to consider that conflict each other, and you have to draw a certain balance, which is why decisions are sometimes, you know, contestable, always contestable. So just to finish, key points: has to be a clear connection to that impairing condition. The research has to be around, you know, supporting people with dementia, people with learning disabilities or whatever, or making, you know, improving services. Consider that justification, thinking about just at the moment, because we are stuck with the legislation, the way it works, ethical and inclusivity arguments aside, something about how the research can be made better, you know, is made better or possible by including people who lack capacity, having a clear process for assessing capacity, making sure there's a clear benefit, not necessarily, very rarely directly to participants, normally about improving care and understanding the kind of how that can be improved and making sure there's minimum risk. Planning those approaches to consultees, who are they, how you're going to involve them and considering their role, what information you're going to give to participants, and how research can be, how participants can be withdrawn, making sure that you make it clear that distress, you know, kind of leads to withdrawal. Okay, thanks very much. There's my little disclaimer I have to say, because we're funded by the NIHR, so the views are mine. Okay, thanks very much.
Great, thanks very much, Martin. That was brilliant. We've had one or two questions posted already, so I'll run through those. But if you have any more questions, please do put them on the chat function. So Martin, Nicola said she's confused by your term HRA REC. She's previously applied for NHS REC and HRA approval, or social care REC and HRA approval, or university REC with or without HRA approval. Is HRA REC something different?
No, sorry, it's a complicated thing. The Health Research Authority is the body that runs and provides research ethics committees for all NHS and a lot of social care research. So the health research, it's often referred to as an NHS REC. Basically, HRA is the organisation that runs NHS research ethics committees. So they are, and the Social Care Research Ethics Committee is one of those Health Research Authority research ethics committees, operating as one of those committees. So that is, it's just an organisational thing. So that's one kind of route to getting research ethics approval. The other route is through university research ethics committees. And universities have different regulations. Sometimes you do need to go through the university rec, even though you're going to the Health Research Authority. You need to check that out with the university. Normally there's at least a kind of bypassing of a lot of the scrutiny if you have to go to an HRA rec. Does that cover?
Hopefully. Thank you, Martin. Earlier, Donna said that a lot of research could be stimulated by social care providers, but she hasn't come across guidance on research ethics aimed specifically at providers. And she said a lot of what is written for the academic community can be a bit overwhelming. Do you know of any resources that have been written specifically on ethics for the practice communities?
That's a good question, isn't it? Because it does, I think no, I don't know of anything offhand. I mean, it's difficult because yes, a lot of the guidance kind of assumes that you've got a university support on ethics and so on. So there are the common issues, the things that Mikey were talking about were kind of, those are common to all sorts of research. I mean, those concerns you have to think about. It's the institutional elements and how you actually can do that which differs. So I don't know of guidance that's directly relevant. That's something we can think about. Maybe that's something I don't know what role, certainly HRA possibly, but School for Social Care Research, I don't know if that's something that is something can be considered, because you know, it is, there are some generic issues, but it's the organisation, how you actually get that research done, you know, practically, because a lot of these things is how are those ethical concerns manifested in what I'm trying to do, and what does that mean, and how do I change what I'm having to do? So that is a really good point. I mean, and I think something I think we're trying to encourage practitioner research, you know, research, you know, providers. I think developing partnerships with academics and providers is a really strong way of getting research. I think it goes well with funders, and certainly, you know, is seen well by ethics committees. So that is certainly a good thing. But yes, no, that is a good question. Yes,
thank you. I'm not aware of things either. The only thing I can think of is there's the Enrich website for aimed at care homes to help them become research ready so they can participate in research. I'm not sure it will completely address the points that Donna's raised, but that's probably a place worth looking, Donna. I'll post the link in a moment to the website. We've had a question from Camille. Martin, could you tell us more about how COVID-19 is impacting on the ethics approval process of non-COVID-19 applications?
Well, I don't think it is in terms of the process. I think we're looking at, I mean, the last committee we only had 3 studies, but one of which was non-COVID and 2 were COVID, and 1 was about blood tests. So that was a first for us, really. I think the thing we're going to be looking for is how researchers are going to adapt their research to, you know, the new restrictions, and the fact that taking part in research may be less of a priority at the moment for certain groups of people, you know, and how there's a good need for good justification for, you know, research involving particularly care homes as a very particular and particularly affected by COVID. So I think it's more a case that you need to consider just practically how you're going to change the research and whether it is realistic. And when we were talking in the unit about some research we're going to be doing, and whether actually we can't do what we wanted to do because it's simply not possible, because the research needs to involve face-to-face direct communication on a regular basis. And I think we're kind of thinking about, well, actually that needs to be put off. So I think we need to see that kind of thinking. You know, what is realistic at the moment? What can be done like this on Zoom or Skype or whatever? But how does that affect particularly people who lack capacity or are, you know, in certain vulnerable situations or don't have access to, you know, good computing facilities? So it's about adapting your research to the settings. I think the process will be the same, but those are the kind of issues we'll be looking for.
Thank you, Martin. Is it that HRA are not at the moment giving approval to master's students?
I don't know. I haven't heard that, but then we don't see many master's students come through, and mostly it's PhDs. Occasionally we get lecturers coming with plans that are going to involve master students as researchers, but that is quite rare. I don't know. I think it may well be the case, but we certainly I think PhDs are being approved.
I thought I'd heard, because of the volume of COVID stuff, that, as you said, there aren't many anyway, but that masters projects wouldn't be.
No, I'm sure you may well be right. Yeah.
Okay. So Nicola says that master students are getting HRA approval, but R&D offices are then not approving them. So I think there is a challenge around master's level students still.
Yeah.
And so I think with COVID in particular, HRA are not approving them at the moment.
Yeah. There's so much health research going on that I think that might be the case as well.
Volumes. Yeah. But I know that one of the issues that sometimes comes up with research applications for ethical approval is around the administration of that approval application, and it's obviously it's time consuming, and particularly because there's a need for a high degree of precision in that application. For instance, the reference numbers, the reference codes for versions of consent forms, etc., need to match things that are in the application form and so on. I mean, how significant is that, and does it come up very often when you see applications?
Well, I mean, it's, oh God, I remember doing it myself as a researcher, and it's like, it is very difficult. I think, I mean, it's interesting because the ethics committee doesn't look at that. That's now handled by the HRA admin. Well, admin's not quite right, because they kind of support for committees. So there's a kind of pre-assessment process. And I know I've been picked up from it, and you need to then just match your numbers to what they've said. It's I don't know what the answer is to that. It's just a pain. So it's not an ethics committee issue as such. It's kind of, and actually I think research sponsors as well, they're playing a role in this kind of checking of what documents you have, and the final document meets the number that they have. So there's, and I found increasingly the research sponsor within the university almost acts as a further hurdle to jump through, before even you can submit your process. And then, so yes, I agree. I don't know how, I'm not sure how we can change that. That's maybe the subject for, again, HRA to think about.
But it's just worth flagging, if people have not gone through the process before, that level of scrutiny around the accuracy of the administrative issues is there in the process, and people need to be very attentive to it, because they won't get past that stage if they don't.
No, that's right. Yeah, and it's all about putting things in footers and headers, and yeah, it's time consuming. And I will just, I do think, and I don't know whether this is up for debate, but about how that work is funded. Because at the moment it's excluded, isn't it, from research grants, and it strikes me that, it's always struck me that actually gives a message of it not being important, because it's not being funded, and it takes a lot of time, that process. So yeah, anyway, public statement, I think.
It's good food for thought, shall we say.
Absolutely.
And I was just, when you talk about things like declaration forms for consultees and other forms that are needed as part of the ethics process, are there templates available, or are people having to start from scratch?
No, there are. The HR, and I was looking at this the other day, they're quite difficult to find. But I'll send you the links. We can maybe make sure they go out, the links to, they have some good templates actually. For information sheets, consent forms, consultee information sheets and declaration forms, there are, and I think you've got to remember, and it does say it, but sometimes I think people just kind of slavishly go through all the headings they've got, and you can pick and choose between them, because sometimes, and you've got to watch the length that it then creates. We've seen, 7-8 page information sheets, and it's just, I mean, it's very difficult, because then you say, your information, I've said this, your information sheet's too long, but you need to include this, this, and this. So it's a difficult process, but yeah, I think they're really useful as a way of just making sure you're thinking about everything you need to include. So yeah, I'll send you those links, and we can maybe post them after the event.
Yeah, that'd be great, thank you. And are there any more questions? We've got a few more minutes. Oh, Camille has posted, thank you. Following on the discussion of administrative issues, if your research project follows sequential methodology, subsequent phases where data collected in one phase feeds into the next, and you're applying for ethics approval for the first, for example, what would be your best practice advice to ensure the ethics committee can link up the subsequent phases of one project together in following ethics applications? Thank you very much.
Yeah, that's a really, I mean, it's a good question. And I guess it partly depends on how much the different phases are actually separate research projects. But if you have got a multi-phase study, I think the ethics committee prefers to see the whole thing. So we can see that the whole, I mean, it is this thing about judging benefits and harms and risks. So you see the whole thing, this is what's going to be planned. And then it might be obvious that stages 2 and 3 or 4 or 5, you know, rely on the results of stages 1 and 2. And then you can then, I mean, if it is a case that you've got your plans about what you're doing and how you're doing things, and then what actually is going to change is information sheets or interview guides or particular kinds of observations, then you can commit substantial amendments to show that this is what you're doing in phase 2 and 3, this is how it's actually going to work out. It may be the case, and you might want to do, you know, if they are kind of very separate, you might want to set that out in the initial, say this is part of a program, but this will be, you know, there'll be subsequent applications. I think there is a question in the application form to say, does this link with a previous study? So, and if there isn't, then you can make it clear. And make it clear, you know, keep the reference numbers from one study and make it clear and refer back. Because the record is still there, and you can include, you know, your previous ethics approval that you might have had in a future ethics application, just to show that this is part of a program. So I think we do prefer to see the whole of a study and then subsequent amendments, or even if you do have to do a subsequent application, then at least there's that kind of basic understanding of what the research is. You're muted, Mike.
I'm muted, yes, okay. Thank you, Martin.
No, I'm just too eager because I always do it myself, so it's very pleasing.
Great. So there don't appear to be any more questions. We have 5 minutes left, but I guess people won't mind after 2 hours sitting in front of a screen if we finish a little bit early. So I'll just say thank you very much to Martin and to Mikey for fantastic presentations. It was a real shame that we couldn't do this in a face-to-face environment, I think, and then people could have asked a few more questions, because I'm sure there are lots there, but hopefully people will get a lot from this. We'll make the slides and the video available online shortly, and everyone that registered will be notified about that going live. So you'll be able to get the information there. And I guess Martin and Mikey would be okay if you had any further questions to follow up on, to contact them directly. Also, I'd say thank you to Daniel for helping to organise today's session, and to Angie for generally helping to organise the comms and impact work of SSCR. I'd say if people have suggestions or topics that they'd like to see in future seminars around research methods or around building a research career, such as writing grant applications and so on, please do let us know. We'll organise those. But just to note that next Tuesday, the next SSCR webinar is on various dementia research that the School for Social Care Research has commissioned. So that's everything for today. Thanks again to Martin and Mikey. Thanks everyone for joining us. I hope you found it useful, and I look forward to seeing you at future events. Thanks everyone. Bye-bye.
Thanks.